Hi, everyone. Welcome to the next episode of the Medicine 3.0 podcast. My name is Dr. Catherine Isaac, and I'm one of the Bionic Health physicians. Today, I have the privilege of speaking with Dr. Julie Siemers. She is a patient safety consultant, an industry leader, and a nurse educator. And I'm super excited that she's here to speak with us today regarding a topic that is very important, which is patient safety and reduction of medical errors. Thank you very much, Dr. Siemers, for being here. Appreciate having you, and tell us a little bit about your very interesting career.
Well, first, thank you for having me on here and speaking to your audience. I feel privileged to do that. Yes, I've been a nurse since, 1979, so many moons ago, right out of high school. And it's been an interesting trajectory of following my heart and following my passion. I think that's one thing I love about healthcare is that you can learn something and do it well. And then if you're like me, you're like, ooh, that looks fun too. So I kind of traveled the course of starting my first job in the oncology unit and then going to the cardiac step down and then ICU. And then from there, I went to critical care transport and then spent 10 years as a flight nurse on the helicopter in Las Vegas. And then the last 15 years has been in nursing education.
Wonderful. Excellent. Working as a flight nurse, that's pretty intense and super important work. Is that what got you sort of interested and passionate about patient safety, or was there something else that kind of helped to, position you in that area?
Yeah. So when I started my master's degree, when I decided to start teaching nursing, I had my bachelor's, but I wanted to teach in the classroom. And I had to pick a thesis. And honestly, my professor said, why don't you talk about failure to rescue? I was like, I don't even know what that is. I'd been a nurse, obviously, for quite a few years by then. And as I did that research, I'm like, oh my goodness, I cannot believe, honestly, the patients are dying from medical harm.
Yeah.
And that began that research. And then I continued with my doctoral research on that topic because, again, I was just stunned that so many in healthcare aren't even aware because we don't talk about it.
Right, right. Interesting. Tell us about failure to rescue. What is that exactly?
It is failing to recognize when a patient begins to deteriorate. And there's three parts to it: failure to recognize, failure to act, and failure to communicate. And it really is that window of time. And I say the nurses because they spend 12 hours with the patient. The doctors come in, make their rounds, and then, they're on to the rest of their responsibilities. But the nurses are really the ones spending the time. And it just was so surprising to me to find that all these signs of deterioration are physiological. And yet we don't really teach as a package, so to speak, about what that really looks like of early signs of deterioration. And so that was really, to me, I thought, well, why do we not package this together so it's something that the awareness is there for the nurses and healthcare providers to understand. Watching for respiratory rate that's increasing or decreasing is the number one earliest and most sensitive indicator of patient deterioration, but it gets missed most of the time.
Absolutely. Yeah, that sounds like something that would be basic, but I could definitely, I've never heard the term failure to, was it failure
Failure to
to,
rescue. Mm-hmm.
failure to rescue? Yeah, that's the first time I'm hearing that term specifically. It seems like that should be something basic and critical. Since you did your doctorate and made that kind of the mainstay of your focus, has that something that's become more essential to nursing education?
Yes. So I go into each of my seniors' classes and give my 1 hour lecture and give them examples of missing those signs of deterioration. um,
Mhm.
and really trying to get it into the curriculum and then teaching other educators about the topic too. It's nothing new. I mean, we teach about vital signs, we teach about recognizing neurological changes and all those things, but we don't really put the focus on it to it is really a thing when the research tells us those physiological signs and of deterioration start 6 to 24 hours before an unplanned cardiac arrest, but we're just missing them. Yeah.
Right. That's amazing. You started to mention some of the signs. You mentioned respiratory rate as being a very essential sign that should be monitored. And I know, and I'm sure you do as well, that that's not something that's commonly monitored for
Right.
patients. Can you tell us a bit about that? A bit more?
Yeah. I'll be honest, when I was not taught the reason for respiratory rate, just that it was a vital sign throughout pretty much my career. And that's just how I did my nursing practices. Yeah, that looks about 14, 16, maybe 18. We
Hmm.
counted when they were in really acute distress. We're like, oh, respiratory rate's up to 36. We've got a real problem here. But if you think about it at the cellular level, it makes sense. We think about shock and the supply and demand issue of oxygen, and what's going on at the cellular level is way earlier than what the signs, that patients exhibit. For example, pulse oximetry doesn't fall for a very long time, so
Hmm.
that's a poor indicator. And yes, there's research out there talking about respiratory rate being the earliest and most sensitive indicator, and 80% of the nurses and healthcare providers don't count because they don't understand really that how significant it is.
Hmm. Right. Absolutely. And it's important because as you increase your respiratory rate, it's a sign of fatigue as it continues to get higher, and also it can be a sign of acid base
Yes.
imbalance. Correct.
Yes, for sure. The CO2 builds up or blows off, whichever we're doing, tachypnea or, too slow, too fast breathing, for sure.
Hmm.
Those chemoreceptors are very sensitive to, the buildup of carbon dioxide or blowing it off too much. And it's yeah, a real, when you notice it, you're like, oh my goodness, that's what's going on. This is what's happening before other vital signs change many times. Heart rate,
Absolutely.
blood pressure. Yeah.
Yeah. Can you mention any of the other important essential vital signs that should be monitored?
Yes, I mean, heart rate and blood pressure are always, but they're not the earliest indicator, but they are really important because they kind of paint this physiological picture. The way I try to explain it to someone is we have this continuum, and on one end, the patient is healthy, and most of our patients are not even close to healthy, right? It's, at least in the acute care setting. And then
Hmm.
the other end is dead. And so the patient is always on that continuum somewhere and can change minute by minute, even with our interventions or medications or that type of thing. And it really is, especially the nurse's job, because they're there monitoring to see how is this patient doing. And when we do our assessments, are the breath sounds matching, the ABGs or the chest x-ray? It's really painting that clinical picture that we need to focus on to really understand physiologically what's going on with the patient. The other really early one is neurological changes. So I think that gets missed or minimized frequently enough, because if the nurse is running in the room because they've got 6 patients to take care of and blood to hang and, blood glucoses to check, and now we're getting admit from a new patient from the ER, it's easy to not pay attention to those signs. But I think this is where communication with the family comes in, that I think is so essential. They can tell us, hey, mom is not acting like herself. And that should be, as healthcare providers, our clue to say, really, tell me more, instead of, okay, I'll be back, and catching those early signs.
Absolutely. So I think that leads into a good next topic, which is so you've written this book, Surviving Your Hospital Stay, and you are trying to provide patients and families the important information that they need to be able to advocate for themselves. Can you share some important tools that you recommend they are aware of or that they use?
Yeah, thank you. Healthcare has gotten just extremely busy. The patients are much sicker than they were 10 years ago or before that, even. And the healthcare team, nurses, physicians, respiratory therapists, phlebotomists, everybody is kind of running with trying to keep up with all of their tasks they need to do. And that's why I thought it was really important to help educate the family on what should they expect, how can they help out, and be a collaborative part of the healthcare team. And when we rely on each other to say, hey, something's going on with my son or something's not right, that we really tune in and listen. So the book covers different areas like how to pick a hospital, how to select a provider that you can actually have a really good rapport with and mutual respect, and um, And then just different scenarios if you're a family member or yourself are in the hospital. If there's an IV running, it should be checked to make sure it's patent and it's not the blood backing up and it's the right rate that was ordered. Those simple things the family really can help with in just watching and observing, and asking for help when they see something that doesn't seem quite right. I'm not trying to make them nurses or doctors with this book, but just enough awareness. For example, when there's a tube feeding going, the head of the bed shouldn't be flat. And if it gets left there, we need to put it back up. Um,
Mm-hmm.
and the catheter should have urine in it. That tells us that the kidneys are perfusing. Just kind of some of those little tips that they might. And then surgery, I think that's a big one too, post-operatively. Early mobilization and flexing their feet in bed to prevent those blood clots and making sure they use the incentive spirometer to blow up those little alveoli and prevent pneumonia.
Right, right. Excellent. Yeah, I had watched some of your other podcasts, and I heard you talking about how the surgical checklist is an important component of patient safety. Can you tell us a little bit about that?
Yeah, so I think it's part of the informed consent when the physician surgeon speaks to the patient and their family about what the proposed surgery is and what they're going to do. And they're actually supposed to mark the surgical site when the patient is awake and talking about it is this left leg that we're going to do surgery on, correct? And just making sure everything's aligned, because unfortunately mistakes still are made with wrong site surgeries. And that's a big piece of it. And then follow up post op care, really looking at the whole patient journey from pre op to intraoperatively and then post operatively to make sure that that patient is getting the best care. And that's again where families can come in and say, hey, dad, you haven't coughed in a while. Come on, get that pillow around your belly. If they understand why, they can help out.
Right. Is the post op care something that's part of the surgical checklist? Is that
It's
something
not part
included?
of the surgical checklist, although it should be that continuum, right? Uh,
Mm-hmm.
but yeah, the surgical checklist should have on there the planned surgery, the patient's, signature, and then the surgeon, I believe, is supposed to initial the surgical site as well. Uh,
Mm-hmm. Mm-hmm.
but I heard some statistics recently that only 69% of hospitals used the World Health Organization checklist. And I thought that was really interesting. Not sure why it wouldn't be mandatory to use it, because it does prevent 30% of morbidity, mortality when it's used as intended. So,
Right. Wow,
yeah,
that's pretty interesting.
yeah.
I have no explanation why only, as you said, about 70% of hospitals are using that. I think in general, healthcare workers definitely feel inundated by forms and paperwork that they have to be completing. But that seems like an essential one that should be a part of patient care, patient safety. Absolutely.
I would think so too. The only thing I've read in articles is that some of the surgeons will complain that it takes too long to do, and they must have confidence that they're going to be doing the right surgery, and but still mistakes happen. And I think just like the airline pilots, it doesn't matter if they've flown 10,000 hours, they still must use a pre-takeoff and a landing checklist every single time. They
Yeah.
have one and the co-pilot has one. So
Right. Right. And so, what other things do you recommend for patients and families to be aware of? Do you think it's useful to be aware of kind of some of the major medical errors that are made so that they can just be attentive during those times? Like, as you say, I mean, prior to my dad having his joint replacements, I actually like labeled the area before even sending him off to the hospital to say we're doing this knee, not this knee, and putting like an X over the one that wasn't going to be operated on, and writing not this one,
wow.
to make sure. Are there kind of certain scenarios where you recommend patients and families be aware and kind of keep an eye out for certain things?
I think, I just did a little TikTok on this story the other day about a patient who was discharged from the hospital. They were trying to regulate her cardiac meds, and her heart rate was 127. And so just knowing normal vital signs as a family
Hmm.
member, I would not take my mother home with a heart rate of 127. And
Right.
fortunately, she got out of her car and was dizzy because her blood pressure was low due to her fast heart rate. And she fell in the driveway and got a compression lumbar fracture. And
Oh,
it's just, you know, it's those things to just say, hey, I noticed my mom's heart rate is higher than normal. Normal 60 to 100. And
right.
staying up there is like something we need to take a look at and figure out why.
Yeah.
And so knowing normal vital signs ranges and then asking questions. And it isn't to be controversial and the pain in the neck patient is to say, hey, I've got to take mom home. I need to make sure she's okay. So knowing vital signs, asking what to watch for, especially if there's been a head injury, what do I watch for that I know that, my dad would need further care, or what should I be concerned about? Um, and I think just the physiological functions of, normal urination and bowel movements and, all those things are just being in touch with what's normal and what should we expect,
Mhm.
and asking questions.
Yeah, as you're talking about this, I'm just thinking like I'm imagining that scenario in my mind at the time of discharge. Everybody's excited for the family member to leave, waiting for the paperwork. Maybe they've been waiting all day to get the final, approval for discharge. And, the nurse will come with the discharge instructions and read through it. And sometimes you're just so ready to leave, it's kind of hard to focus.
Yeah.
And sometimes it's also just a matter of like a huge download of information when you're already feeling quite stressed and having difficulty focusing. But it seems to me like it would be very essential to have almost a series of videos that are created
Yeah.
where, discharge from the hospital after joint replacement, discharge from the hospital after cardiac surgery, discharge from the hospital after pulmonary embolus, or something like that, where a patient and their family can go back and use that as a resource later on to view exactly what you're talking about. Like, okay, here's a description of basic vital signs. Here's a description of, maybe how best to organize your medication and
Mhm.
how to set up a schedule for yourself or your family member so that they can make sure that you're getting your needed medications at appropriate time, etc. Are there any resources like that exist?
Not that I know of, but I think those are perfect. And maybe hospitals do have some short videos, but I think, as you mentioned, that when the patients can get home and their family members, when things have kind of calmed down a little bit, you're right, the information is probably more digestible at that point.
Yeah.
One thing you mentioned too, I thought about is the medications, the reconciliation of going home, and making sure that families understand, okay, these are mom's current meds, and
Hmm.
now these are the new ones, uh,
Right.
and
Hmm.
making sure this happened in one of the clinicals that we did a couple years ago with a student. The woman was taking warfarin for her atrial fibrillation at home and then had knee surgery, so then was on the Lovenox. So she ended up taking two blood thinners, and just asking the question, oh, do we need both of these, could be, oh no, we really don't, let me clarify.
Yeah, absolutely. That's critical, and I think there's that whole educational piece that I heard you talking about in a different podcast that you did, where someone was kind of calling it a heart medicine,
Hmm.
and not necessarily knowing what the function of that heart medication was for. So, was it a blood thinner, or is the heart medication a beta blocker, which slows your heart rate down and lowers your blood pressure?
Right.
So, kind of knowing more than just the basics. Oh, this one's for my heart, this one's for my kidney. You know, it is critical, and wondering even about how to better write that information on the discharge summary or the after visit instructions that people receive, because just thinking about it in the after visit summaries that I've seen for my family members and for my patients, I don't think that they kind of necessarily go into the function of the medication or what the class is of the medication. They're kind of just telling you, you should take it once a day or take it 3 times a day, etc. Yeah, there's some areas of improvement there.
Yeah, I think patients are ready for it. I mean, I think in the day and age that we live in now, they can research a bunch of things, but we want to make sure that they're researching the right things, and going to websites that will give them information that's reliable and evidence-based rather than
Mhm.
just some
Yeah.
random information somewhere. So I think they are ready for knowing more and really taking a little more autonomy for their own health. And I think that's kind of the foundation of my platform in helping patients and their families is it is a responsibility for you yourself to know your body, know your medications. And that's nobody's going to do it better than you.
Hmm. Yeah, absolutely. And I think that also brings up the important thing you were talking about earlier in terms of finding a clinician or a clinical team that you feel like you can trust and have good open doors of communication with. Because, even I think that the challenge with all of the information that's available to people is that sometimes it can almost be confusing in terms of where to focus your attention, like what is highest priority.
Yeah.
And, I mean, you can search anything on Google and you can see this long list of 20 potential drug interactions and side effects. And it can be extremely overwhelming. So having someone who can kind of collaborate with you to say, yes, that is a potential side effect, but there's a 0.001% risk for that side effect. The much more significant side effects to be focusing on is A, B, or C, or even saying, yes, that is a known side effect to that medication, but the risk of stroke, if you don't take it, is that much greater. And that's why, it's important and it's being recommended for you. I think
Right.
that can be so challenging for folks to really understand where to focus their attention.
Yeah, I agree.
Great. So, in addition to your book, are there any other resources that you like to recommend for patients and their families?
You know, we all hope that we're not going to be in the hospital someday or be a patient ourselves, but odds are that we will, or one of our family members. And I think, as you mentioned, when the anxiety is high, the stress is high, we can't really process. For most people, the environment of an acute care setting is overwhelming and it's foreign. It's like going to another country, you don't speak the language, right?
Yeah.
So I think the more that we can become informed of our own bodies, our own health, our medications, and being proactive with our health. What you guys do there, I think, is fantastic because it's much easier to stay healthy than try to treat disease. So to keep ourselves in as best shape as we can with eating the right things and moving and exercising is probably the best things we could do. And then after that is becoming informed about, those things that if you've got a heart condition, find out what you can about it and become educated about what are those things particularly for you or your family member, if that's the case. And as just taking more accountability for our personal, I think years ago it was the mentality, the little doctor would come do a home visit and took care of the whole family. And, you just entrusted everything into he was going to manage things for you. And now it's so complex that you may have 4 or 5 doctors, if you've got multiple comorbidities. So,
Yeah, that's true. I agree. And yeah, I mean, definitely that's a huge focus of ours here at Bionic Health, wanting to be preventative and to provide patients the knowledge and information so that they can say, actually, I have a family history of diabetes and hypertension, or I have a family history of breast cancer. What should I be aware of, and how can I actually be proactive? It was surprising in my primary care work how many women I would see who have family history of breast cancer in a first degree relative who are just not necessarily aware that there was potential recommendations for increased screening, for instance. So
oh,
if your
wow.
risk is higher than 20% of a lifetime risk, then you are actually, it's recommended that you have more intensive screening than just your yearly mammogram. And there are many women that I saw that were just, not yet aware of that information, not yet aware that they would meet that criteria for increased screening. So education is huge, and I agree, and I love that you've made that the center of your platform in terms of patient safety. My next question for you, and I think we're going to talk about this a bit because I definitely want to touch on the topics of burnout and staffing shortages and whatnot. But my question was going to be like, how do you feel we best create a culture of patient safety within the work environment when we're talking about healthcare workers themselves?
I think transparency is number one. We talk about a just culture, but have we really implemented the tools that everybody feels psychologically safe to speak up
Hmm.
when they see something? That campaign, see something, say something, I think really needs to permeate into healthcare. There's been a culture of blame, I believe, that just does not serve us. And if we aren't transparent and we don't understand the risks of, oh my gosh, I just almost, did X. Could other people be doing that too? We don't talk about it. Dr. Don Berwick, he was the past president and CEO of the Institute for Healthcare Improvement, talked at a recent conference about second victim.
Yeah,
And it's just psychologically scarring when healthcare providers and professionals end up making a mistake or get close to making a mistake. We don't ever want to harm anyone. But if those are kept in secrecy, or we don't have a platform that supports expressing, we're not going to fix it, you know?
absolutely. Excellent. Yeah, I definitely think that that is a super important thing to discuss in terms of understanding that almost like if you think about the frequency that medical errors are made, and understanding that there's a high chance that each and every one of us are going to make that medical error, that it's almost a systems related issue rather than a person related issue. And seeing it that way, it's more about how do we approach and address the system and optimize the system rather than blame the person that, went ahead and created that harm. They
Exactly.
were simply operating within that flawed system. And yes, that definitely, I think, promotes people speaking up and identifying when issues arise.
Yeah, and I think that it's got to be a number one priority when we think about the amount of harm that's done. And because we don't talk about it, it really isn't in mainstream news. I compare it to, and you may have heard this, but if we take the amount of estimated patients that die every year and we put them on a Boeing 747, that's one and a half aircraft every single day
Wow.
dropping out of the sky and killing everybody on board. And yet, because we don't think about it in that aspect, it doesn't hit our media, it doesn't hit um, our consciousness or awareness, and therefore we don't find solutions. As you said, it's systems errors. Very rarely is it the blame of an individual. It usually is several things that have led to the opportunity to make a mistake. Like when they used to keep vials of potassium at the bedside.
Right, right.
Like, whoops, that wasn't Lasix I just pushed.
Right, right. Yeah, that's so amazing. I've never heard that
Mm.
statistic, and that certainly is frightening to hear it described in that way. And yeah, I definitely think again in terms of talking about education of the healthcare staff. Letting them understand that the number of errors that are occurring on a daily basis is that frequent. I think that changes things dramatically as well.
Yeah, for sure. If we think about, again, every patient is someone's family member. You know,
Mhm.
I mean, when my parents had their airplane accident and I'm living in Florida with 5 children, working full time in the ICU, and they're in Oregon State, you just pray that the healthcare team will take care of your family members like you would if you could be there. I think we should have the confidence that they will be taken care of like we would do that. And I don't think many of us have that right now.
Right, absolutely. Yeah, I'd like to now talk about the problem of burnout as it's affecting our healthcare workers, because I think that, I mean, we know that there's a relationship between burnout and medical errors.
Yeah.
I also think it complicates how we go about addressing medical errors. So let's talk a little bit about that. Can you share what is burnout, first of all? And then let's talk about just the prevalence of how many healthcare workers are affected.
Yeah. I would relate burnout to what I felt when I worked on the oncology floor. And this was way back in 1980, my first
Mhm.
job in the hospital. Um, and I didn't realize that's what it was called then because it wasn't the buzzword that it is now. And I don't think it impacted so many. But for me personally, I, of all people, all patients, wanted to sit and hold their hands and listen to them talk about their life and their stories and their concerns and am I going to die? And here I am in my head thinking, I have to go hang blood in the next room. And I've got antibiotics that are due timed because we've got vancomycin, blood draws, peak and troughs. And I've got, you're thinking of all the tasks you've got to do. And you don't have the capacity to sit there and be as compassionate as you really want to be because you and now somebody just fell in the bathroom next door, you got to run over there. And so I think that for me is the best explanation of when healthcare providers want to truly give to their patients who are in need, whether it's physically, psychologically, spiritually, and yet you don't have the capacity because you're overburdened with so many tasks.
Absolutely. Yes. And I think the other important thing to know about burnout is the lack of self efficacy that healthcare
Mhm.
workers experience. So just feeling like no matter what you do, you're never successful and that the goal line is always moving. So when you think you've achieved whatever you need to achieve, you realize actually I'm not there. There's a whole additional number of tasks that need to be done, or just kind of really seeing yourself as not being qualified or doing quality work and
Yeah,
feeling the pain of that experience,
you're
going
right.
home each day and not feeling like you did a good job.
Yeah.
Certainly can make it difficult to want to wake up the next day and continue to keep going. So yeah, burnout is tragic and unfortunately really common. Can you tell us a little bit about how many people are affected? I mean, the numbers are quite high.
Yeah, I know that, and this is tragic because we're short so many nurses. But there was a study done about 5 years ago that said almost a third of them leave the profession within the first 3 years. And here we are struggling to educate more students to become nurses. And, one of the problems with that is not enough nursing faculty. So it's this perpetual problem. But if we can't catch up because they're leaving the profession, then we're just chasing our tails on that darn hamster wheel, right?
Mhm. Absolutely. Yeah,
Yeah.
that's something I've witnessed in prior work that I've done where, we were short staffed, particularly during the COVID pandemic. We were short staffed and then hiring new people on. And prior to the pandemic, we would have time to kind of train those new healthcare workers. They would be able to shadow other people on the floor, and they would have a whole process in which they were integrated into our system and say, okay, now after, let's say, 3 or 6 months, they're able to operate independently. But during the time of the pandemic and afterwards, where we were dealing with such great staffing shortages, that, we called it like a ramp. That ramp was shortened so that they were operating independently in a much shorter period of time, which meant that there was one, greater chance for making errors, and two, just a much higher likelihood of that person becoming exhausted and burnt out much quicker because they did not feel prepared to be able to do the full level of work that they were doing in that short period of time.
Yeah.
So it was a catch 22 sort of situation because they would come on. And as you said, within a short period of time, they would decide, okay, I can't continue to do this work. And that staffing shortage would just continue on and on. New person in, burn out, leave, and then, working short staffed again. New person
Revolving
on,
door.
yeah, so that was really really difficult. And yeah, I think bringing up the point that it's not only burnout that's the issue, but the consequences of burnout, which is the staffing shortages, then, because a lot of people leave their jobs.
Right. Well, and I think you brought up a really good point. Most human beings want to have a feeling of fulfillment, especially in the healthcare. If we're drawn into this profession, we want to help and make a difference. And when we feel like we can't, because like you said, we're just doing the same stuff over and over again, day after day, and there's not that cap, that frosting on the cake that of a job well done, right?
Mm-hmm, mm-hmm,
We might get little snippets of it like, yay, Mrs. Jones went home,
mm-hmm, mm-hmm.
So it's tough.
Yeah. And actually, when I'm thinking about burnout, over the course of my day, I would see 18 to 20 patients a day. And even if I would have the successes where one person lost weight, somebody's blood pressure's under control, or maybe even we identified a cancer early enough where the person's going to be able to be treated, there would inevitably be one or two things, even if they were small. A patient was dissatisfied with this, or they didn't get a phone call back in time where they felt that was reasonable response time. It was like it would just cut off any of the positive experience right at the knees. Like, oh well, none of that felt gratifying anymore because there was a complaint about X, Y, or Z. And when I would experience that, I would say definitely recognize that was burnout within myself. It was like the dissatisfiers greatly outweighed any of the accomplishments.
Yeah. I think part of it too is when we've got compassion in our hearts and we have patients, like, again, I'll go back to the oncology floor for just a minute, but a 40-year-old mother was dying of breast cancer, had a 16-year-old son and no family, nobody to help take
Oh,
care of him.
that's terrible.
Yeah. And it's just like, it just weighs on you and tugs on you. And because there's things we just can't make better, and that's tough for us that want to fix and heal.
Absolutely, absolutely. So, can you tell us about any maybe like state level or national level policies that are out there in terms of addressing patient safety and or burnout? Because one of the things we didn't mention is that when healthcare workers are burnt out, they're much more likely to make mistakes.
Right.
And so I don't believe that you can address one without addressing the other.
Absolutely true. You think about when we're emotionally shutting down because we're exhausted emotionally or psychologically, spiritually, we don't have the same attention. We don't have the same, um, what's the right word, focus when we're even drawing up medications. So I think that's a big part of it. There was, in 2023, a report submitted to President Biden called the PCAST. Are you familiar with that?
I'm not.
The President's Council Advisory of Science and Technology. That's what PCAST stands for. And it was a 28-person, the experts in the field, and again, science and technology, et cetera, they all came together, and it was patient safety was the number one thing that they felt was important. And they'd had a whole plan. I can send it to you if you like.
Sure.
But there was some phenomenal suggestions in there. And last I heard, it was on President Biden's desk. And hopefully we could get that signed or even some pieces of it. But one of the recommendations, for example, is a national patient safety committee, like the NTSB, the National Transportation Safety Board. So,
Mm,
for example, when there's an airplane crash, they check everything that they find, because they want pilots and mechanics and anybody who would operate like a Cessna 171 or whatever, that to be aware of what they found with this crash. And so it would
right.
prevent, and the airline industry has had amazing success over the last 5 decades of preventing, crashes and harm to people. And healthcare, we haven't. And so right now, if harm occurs to a patient, there's nowhere for that patient's family or them to go to say, can't somebody help me? Whereas if we had a national council that would have patients, family members on there that could help. I know there's a lot of independent, smaller advocacy groups and trying to get policies changed, but for some reason it's quite difficult at the larger level. But there was a lot of great recommendations in that PCAST. One of them was transparency, accountability, and mandatory reporting. Because
Hmm.
right now, sentinel events aren't mandatory to report.
Oh, interesting.
Yeah. And so when it's voluntary, you get just a fraction of what we truly think is going on in much larger numbers, which is sad.
Right.
Yeah. But again, that's that accountability and just culture and transparency. There just has to be a complete culture shift all across.
Mhm. It's interesting as you were talking about the reporting piece and sentinel events. I was thinking about my last position where if there was a near miss, which means like a medical error didn't actually occur, but it could have, or harm didn't occur, error occurred, but harm didn't necessarily occur. Um, that there was a system for reporting everything, but the amount of documentation that was required to report that event was a barrier in and of itself. And not that it actually took that long. Let's say it took somewhere maybe like 10 minutes to complete the documentation. When you think about the amount of documentation that physicians and providers had to complete over the course of the day, um, adding an additional 10 minutes of documentation just feels like insurmountable when you know that you have an additional 1 to 2 hours of work to complete that evening after you finished your clinic day.
Right.
So it seems to me like one of the simple things to do initially would be to remove those barriers to even just completing the documentation, so that more data can be collected, and then people can be reviewing that and identifying where the issues are.
Right. I just read an article a couple days ago in CNN, and it was referring to the latest article that came out on patient safety statistics from the British Medical Journal.
Mhm.
And Dr. Bates from Harvard was saying in this article that most hospitals do have policies to review charts where patients were harmed, but they don't get to them very often. So, similar to what you're saying. And he said we only capture about 5% because the chart reviews just aren't done. How
Interesting.
then do we ever collate, and bring all of this together to say, um, this tube feeding connection actually fits into an IV? We can't have that. That's got to change because there was patient harm that was done.
Yeah.
So on occasion, we catch some of those things, but it makes me wonder everything that we're not.
One of the things that I thought of right as you were mentioning that, if there are a number of cases that aren't actually reviewed, that would be a great area to use AI to, review the cases and pull out and identify like a recurring series of patterns that they might see in, certain cases on, let's say, the oncology ward or
Mhm.
cardiac ICU, or and you wouldn't have to use manpower to just start doing some basic review of that data.
Yeah.
That would be definitely an area of optimization.
I think when they did To Err is Human report back in 1999, and it reported up to 98,000 patient deaths.
Mm.
Then when they did, and that was all paper charts. And then when they did in 2013, the study retrospective chart reviews, but used electronic health records with what they call the global trigger tool, the GTT.
Hmm.
Oh no, this is more like 250,000.
Wow.
So it's again collecting the data in a manner that is really speaks to apples, right?
Hmm.
But from what I understand from this patient safety conference in September that I went to, we can't even agree on what patient harm is, meaning how far do we take that,
Hmm.
in the definition. And so we still need some structure around that too, to
Yeah.
help together.
What's the debate in terms of the definition of patient harm? Are you talking about like including things like near misses, or is
Right.
there something different than that?
Yeah. So it is okay. If harm did occur, was the patient permanently injured? Were they partially injured? Were they, just had a rapid heart rate for a little bit and now they're fine? So do we count that? I think the expanse of what could be included in there is where they're trying to create at least a common definition that everybody can buy into.
Right. Right.
Yeah. Where do we draw the line, so to speak?
Yeah, absolutely. Great. Well, this has been tremendous. Is there any kind of additional sort of things that you feel like are important to communicate to the audience before we finish up our podcast?
One thing I love to share every time I have the opportunity is the CUSS words.
Okay.
So it is when a family member or patient or anyone is concerned, uncomfortable, scared, or there's a safety issue,
Mm-hmm.
that use those key words to get the attention of the medical provider, the nurses, whoever, and just get their attention to say something's wrong or something's not quite right. Is just a way for you to empower yourself to speak up and say something. Say something is hard.
Mm-hmm.
That we still have this hierarchy, where we've got these levels of what we consider, what's the right word? Power. I'll just say it. Versus, and the patient usually is the one who feels the least empowered because they don't have the medical knowledge. But that's where I think we need to come together and collaborate and have that equal back and forth dialogue, as you mentioned earlier. And so speak up if you think something's wrong, get someone's attention, but use polite manner and be kind and compassionate in how we communicate with each other, I think is another a tool that just for every day, not even just for healthcare conversations.
Absolutely. And those are challenging things to do, especially when emotions are high and people aren't feeling well. But having just courtesy goes a long way.
It does.
So just to reiterate, you said cuss words. So C was concerned, uncomfortable,
Scared,
scared, and
safety issue.
safety issue, and to make sure to communicate to your healthcare team to let them know. Yes. I think that's excellent. And one thing that I think is important, just to kind of reiterate what you're talking about, is that sometimes you kind of can just get a sense, like, I just don't feel right. I can't necessarily explain why, or can't, identify a particular thing, but I'm just not feeling well. So even being able to say, I feel scared, something doesn't feel right, is enough to be able to, encourage someone to speak up.
You're right. That intuition, we all know, we all have it.
Mm-hmm.
I would love to do research on that someday to figure out what it is, where it comes from, but it's a real thing. So pay attention to it.
Absolutely.
Yeah.
Well, this has been so wonderful. Thank you so much for taking the time to speak with us here at Medicine 3.0. Where can our listeners find you and find more information about patient safety?
Thank you. So pretty much all the socials, LinkedIn, Instagram, TikTok, and then my website is Dr. Julie Siemers. So,
all right. Excellent. Well, thank you again, and really appreciate chatting with you.
Thank you. All right. Bye-bye.
Thank you for listening to another episode of Medicine 3.0. We make this podcast so that you know where to turn for good information on keeping you and your loved ones healthy. Feel free to check us out at bionichealth.com, where we can help you live a longer, happier life.